had a few hiccups there. I'm Regina Nantege, and I'm going to be sharing with you the benefits of prompt nutrition care. And like I said while I was starting, my goal is to have that at the end of this meeting, we have each of us able to at least have that provision of nutrition care all through the different activities we have in our health facilities or even community health aspects. I am a dietitian and I'm happy to be here. So, why do we need nutrition? But we are not sure what they're eating. But when we do analyze and ask people, what do you eat for breakfast, for lunch, etc., we notice that some of the diets that people have are lacking in, for example, vegetables. These diets are lacking in sufficient fruit, and they may be high in unhealthy fats like cholesterol, high fat, etc., which we shall see later. But that's not the issue. Maybe it's okay to have an unhealthy diet. But the problem is that diet is the biggest modifiable risk factor for disease, that if people stopped eating unhealthy and modified their diets, things as simple as eating more fruit and vegetable, would actually have less people having problems to do with non-communicable diseases, and of course, even the normal underweight burden that we have, for example, in Uganda. And we also know that most of our health facilities don't actually get to have a nutritionist see each of the patient or the patients. So meaning that we end up having the patients walk out without that opportunity to make healthier food choices that could minimize the disease morbidity and, cases of mortality. And for me, this is very important. And I hope it will be for you too, because we are in a country where people still have to borrow to get adequate healthcare. One of us or all of us have had a chance to have to contribute to someone's health bills, especially if they have a chronic condition. What does this mean? It means people will struggle to provide the appropriate health care for themselves. So if we have something like food that is modifiable, that people could eat better and they reduce the risk of disease, or if they have disease, they could have less burden of that disease, then that would be a very beautiful thing and very cost effective. And I'm sure we all wish our patients better health. And as I talk about this, I'm going to start with the aspects of course, undernutrition, and then later on going to the other concerns like obesity and how do we provide care for this. And in case you have questions all through this process, kindly share in the chat. And these are our numbers. One in every three children are stunted according to the UDHS 2016. And that's just a slight drop from 33%, wasting just a drop from 5 to 4. So the numbers are still, up there. But of course, we have had some improvements. Then in terms of micronutrients like anemia, for example, if we are over 100 females on the chart today, we have 53% being children, 53% being anemic. That's 1 in every 2 children. You have 2 children at home, 1 of them may be anemic. You have 2 children in a community, 1 of them may be anemic. That's a big number. And also for the women, 1 in 3. Luckily for us, almost every other household in Uganda today is using iodized salt, and so we have less iodine deficiencies. And then the concerns for me and for you as a health provider, because you want to provide better health. We are seeing that there is no significant reduction in anemia. People are getting more access to supplementation, but there is no reduction. If we still have 53% of children being anemic, that's sad. Then the other concern is that as long as we continue still having some people underweight, stunted, we have more people probably cycle. When you are underweight, as we shall see, stunted, the ability for you to be productive in life and, overcome poverty is harder. So you end up coming back into the same cycle. So it's worrying. We may be from facilities where we have not had this time to have some of these people, but then we have other facilities where we are seeing these cases. So it still affects us as a country. And then while we struggle with the underweight, anemia, we still have other issues coming up, like obesity is increasing. Especially among women. So this is, and there's also a predicted reduction in breastfeeding for working mothers. Any mothers know that if you had to go back to work after your maternal leave, you're worried about how you're going to be able to feed your baby. So meaning we might be having less children accessing adequate diets later on, because we are getting more busy over the days if we don't help ourselves put in policies or actions to help with increasing breastfeeding. But anyways, these are just numbers. What actually matters to us is what we do in day-to-day practice that can actually create differences. And again, these are reminders to opportunities for us to have those benefits of prompt nutrition care. And if any of us has had an opportunity to be a part of a team that is helping a child or an adult who has acute malnutrition, these are some of the things you would have to do. You would have this child walking, like, for example, we have a few pictures there of a child who looks very hungry, and indeed they are suffering from acute malnutrition. You can't see by the tape measure that they're measuring their arm, they're very underweight, they're doing their check for the edema, they have edema. So there's so much going on. This child needs help. And when they walk in, they have hypoglycemia. You manage either with IV, dextrose, or you give oral glucose and give more frequent feeds so that you can manage the hypoglycemia. That's in the first minutes or hours of coming in. And then you start conscious feeding. And by conscious feeding, we mean you give a therapeutic feed where you're saying, I'm giving a certain amount of protein, a certain amount of energy. And so we have these formula feeds that are specifically having that amount of energy or protein. We start with the F75 and then go to F100, which is just to ensure that we are not overloading this body that hasn't been receiving sufficient nutrients with so much at a go. So we are loading in little at a time, usually between 2 and 3 hour feeds. And this requires a lot of attention. It doesn't require only the person who is saying, have this much. It requires the whole healthcare team, because providing these feeds all through the day requires even some nightly feeds. And that means that if you're an administrator in a facility, are you taking caution about these roles that have to be undertaken during these times in the night to provide these frequent feeds? Are you referring these people with acute malnutrition to appropriate facilities that have the capacity to provide those feeds, frequent feeds? And then, of course, we manage dehydration with a specific rehydration formula so that we're not having issues with electrolyte imbalances. And also, when the child diuretes, refeeding immediately after fluid loss, like they've had diarrhea, loose motion, or vomiting, you refeed so that we prevent dehydration in this child. Those are some of the things that we end up doing. We won't go into the details. Are these things amazing? Yes, they are. Are they being done in all health facilities? It's possible, but then it requires you to just be willing to manage. Every time you have a patient who has severe acute malnutrition, you should pay attention to the nutrition. Does it just always come in as, we have that malnourished child alone, like in Wanamjimu, where it's just that malnourished child? No. Most of the time, it also presents to us as a child who is having malnutrition, the acute malnutrition, but they also have another medical condition happening. They have malaria, they have congenital heart disease, they have something going on. And you also notice their numbers are not doing well in terms of the weight, they have edema, so they have acute malnutrition. But sometimes, at least for me, I've had a chance to witness when I was in a hospital where mainly people will focus on, how is the malaria? Are they progressing? Are they due for surgery? Is there going to be, when is the surgery set up? Are you giving the medication for their heart disease? But sometimes we forget to take care of the severe acute malnutrition that is happening to this same child. It seems like the other condition, they have this disease, then they are also undernourished. But it's not just the other condition, it's the condition that could predict the outcome of your care. So I'm just here to remind you that when you have patients, leaving the numbers aside of, 29% are stunted, 11% are underweight, etc. On the day-to-day basis of our practice, if you paid attention to these symptoms of malnutrition and address them, you would actually have better outcomes, quicker recovery in these patients for whatever condition they're coming up with. So, in case you have children presenting with severe acute malnutrition, please address it, because you will always have better outcomes for all the other conditions you're addressing. And when they leave the hospital, definitely they are supported much, much more than when they're in hospital, because nutrition is made at home. It's not only made in the hospital. So they're given ready-to-use feeds that they can use from home, or counseled on how to use the foods that they have around them to provide a healthy diet. The word counseling is very key, because we all have different foods that we have access to. So I have to be told what I can work with the options that I have around me. So, like I said, my mission today is to show you that there are things we do and they have big impacts on patient outcomes in terms of nutrition. That's just one of those things you should take home. The second is about stunting. We have our nice map over there, and I'm sure that we can use this to also zoom in on our own region as Busoga Health Forum and compare it to all the other regions. In terms of stunting is the chronic version of malnutrition. We're talking about the acute one where the person is already underweight and they're having a micronutrient deficiency. But if this remains with the child over time, it actually affects their growth. So they become too short for their age, too short for their age. So meaning they're not growing as they should have grown. So you see there, so guys, at 29%, which is similar to the national prevalence. So meaning that 1 in every 3 children are stunted. But what can we do about this? As clinical practitioners, there is still something you can do. For every mother who gives birth and you have that chat with them about early initiation of breastfeeding, helping them put the child to the breast. I've had a chance to visit hospitals, for example, when people are having their labor, and after giving birth, one of the things that you hear in the labor in the maternity ward is mothers and their relatives coming in to tell them, no, if there's no milk, you do this. If there's no milk, do this. If there's this, while they're within the hospital where there are professionals to guide them. You have people walking and advise on so many ways to feed this child. Some of them right, some of them wrong, and some of them causing the mother stress. Because everyone is saying, no, do this, that milk is not enough. Meanwhile, is there anyone giving them the actual tool? Is there any of us who has a facility that has maybe a small leaflet of guide to attaching your baby right? I don't know. So that mothers know that it's possible to get sufficient milk, and so that mothers are not panicking when they have that first latch and there's very little coming out. Is there someone reminding these mothers that that's okay? Tomorrow we'll have a better supply. And even that first latch is important. So I'm just here to remind you that it may take just 30 seconds to just tell a mother, by the way, in case you need support with your breastfeeding, I'm around. Because we might sometimes think that mothers know, but we have also seen that even with repetitive, with pregnancies beyond the first pregnancy, someone can fail to have sufficient milk for their fourth baby, but you read that this is their fourth child and you think it's obvious they know what to do, so you let them go. They're in a very different situation this time. They could be stressed. They need that support. So it's important that we do not undermine the effect of counseling mothers about supply, because if we do, we are saving or reducing on the number of stunted children, because that is the adequate diet they can get on day one. And all through the 6 months. And of course, we have to guide the mothers who are living with HIV to ensure that, they know that they can feed their baby without causing a transmission from the mother to the child, but also to guide them so that they do it in a safe way. So I'm reminding us to be cautious about this, different ways we can help mothers feed right to prevent stunting, of course, and also ensure a good growth. And also, we have started with things that are a bit obvious. We are saying everyone should eat. The baby's food is the milk. Why not give it? And then guidance to the working mothers who come into our facilities. Most of them don't know even about the option of expressing milk. They don't know that you can express milk. So I'm just here to remind you that let's tell mothers about these options. Tell them you can express your milk. Tell them about the fact that when you express your milk, you can actually have easy storage and less contamination. Because if I express my milk, I put it in a small bottle. Let's imagine my baby feeds on 60 ml every 2 hours. So I'll get 60 ml bottles, put the milk in 60 ml different bottles, and say keep them in a refrigerator. But we also know that breast milk can keep outside at room temperature for a few hours. So this mother will have the chance to express, and the caretaker will only pick up this bottle, one bottle, give the baby. When the baby is done feeding, leaves that bottle for cleaning, picks another bottle. So for me, in my opinion, this is actually a more hygienic way of handling baby feeds. Of course, if this is not possible, then we're going for the infant formula. And if that is not affordable, then that's when we have to guide the mothers on the milk-based feeds. But usually, most of the time, it's possible for the mother to breastfeed and express the milk. And amazingly, I think now we have even breast milk banks coming up. So I'm going to go to the next. Just this was a reminder that if people are feeding their babies right through their first days, 1,000 days, would have less cases of stunting. As you can see, we are not doing so well in our own region. So kindly feel free to keep asking questions as I go on, and I'll be looking at the chat for the questions. Yeah. Next, I'm not focusing on one main topic. You're going to see me progressing from the undernutrition to now iron deficiency, and later going into the different aspects of overweight and obesity. So we are going to keep jumping here and there, because I thought the best way to use this hour is to give you a few insights here and there about ways we can actually impact the different patients that we have. So the last slides, we have already had how we can impact children and adults with undernutrition. And now here I am just reminding you about this amazing nutrient of iron. So, and the approach being that every time someone walks into your facility and presents with signs of anemia, and you go in and confirm indeed it's iron deficiency, say with your lab tests, hemoglobin, serum iron, or any other of those tests, it's important that we ensure that these people are able to get sufficient iron in their diets. 11 milligrams, for example, for women, adult women of iron. And it's possible to do this with diet. You can see a few foods there with iron. And the reason I asked us to share in the chat was also to critique some of our own diets for sources of iron. And so I'm going to just scroll through the charts to just see if I can. Okay, it's not doing it, but I wanted to look at the charts to see what people are eating as of today. Does it have sufficient amounts of iron? Is there liver in it? Is there meat? Is there beef, goat's meat? Is there booga, the red amaranthus? Is there hibiscus, millet, beans? Because these are amazing sources of iron. And for you to get enough, you need about 3-5 servings of this. And to remind, and I also wanted to look at those meals that people have shared to see when people are eating iron, like from beans and millet and booga, which comes from non-animal sources, we know that it's harder for the body to absorb. Are they complementing it with a source of vitamin C so that we have sufficient amounts of iron absorbed, because vitamin C increases the absorption of this nutrient? So this is just a reminder to us that, hello, let's take a few minutes every time we have a person presenting with anemia, just to give them a list of these foods. Because sometimes when our patients go onto the internet to look for foods that are rich in iron, we may not have a list with our local foods. So they feel like, it's not possible to have sufficient iron. So that is our list. And for those women of reproductive age and children, of course, there are options for iron supplementation because most of the diets are really deficient in iron. And as you've seen, we already have a big percentage of people with anemia. Will this impact when we end up helping these people? Yes, it does. There's a good percentage of infant and maternal mortalities, deaths that are linked to iron deficiency. So if people had enough iron, we'd have less of those maternal and infant deaths in our facilities. I think it would excite all of us if, a small percentage was off. I think it's about 20% of the deaths, maternal and infant mortality, linked to anemia. So not necessarily the optimum cause, but it is linked to anemia, that if this mother wasn't anemic, maybe their life would have been saved. So let us just constantly talk about these foods. We could even have a list of these foods up on our facilities so that we ensure people are not anemic. And coming down to the basics that are even beneficial to each of us is if each of us decides to have a diet sufficient in iron, we have reduced fatigue, increased productivity. There's a study just here in our neighboring country where they had women who were anemic provided with iron fortified beans, and so that they increased their iron intake, and you would see there were improvements in their productivity at work and reduced fatigue. They are healthier. So let us use this nutrient as it is, because it's amazing. We are breathing right now. I'm talking, I'm breathing, you're listening, you're breathing. Whatever you're doing, you have some form of breathing you're doing, you take in the oxygen. But if the oxygen has no carrier around the body or something that it clings to, we don't have sufficient all around our body. So if we get sufficient iron in our diet, it's very, very vital for our well-being. So I'm going to take a small pause there as I transition from what I was talking about before, where I was talking about the aspects of undernutrition, and going to the bigger slides for the day, which are about the diet-related non-communicable diseases, which I think could be what most of us are curious about, because we may know about, if you lack this, get this. If you lack this, get this. But most of these on the other side are more a combination of aspects. They are a combination of risk factors. But like I said at the start, that is one of the biggest modifiable risk factors in these conditions. We agree there are so many reasons why someone will end up having high blood pressure, diabetes, why someone will end up having a heart disease, why someone will end up having, say, breast cancer. But that is the biggest modifiable one. So let's look at it and see how we can help ourselves, because it starts with your health, so that you're healthy enough to help others. And why is this a concern? It's because our food environments are changing. So we have, okay, to what extent? I'm just going back in the chart to just see. Should we cater? To what extent should we cater for nutrition deficiency from trace elements? I'm sorry, I'm going back a bit before I go into this, because I want to answer the questions from the other aspect first. So to what extent should we care about deficiencies from trace elements? So every single nutrient that we need in our bodies, let me just go back a bit. Sorry about that. Iron, for example, we need just 11 milligrams, adult female, meaning we don't need it in very large quantities. Micronutrients, meaning that we don't need to get like grams of iron. We don't need to get kilos of potassium. We don't need to get kilos of sodium for us to have sufficient, because someone can even present when they have low sodium. We don't need to have so much of them. We just need small quantities. The problem with those micronutrients is that you need to eat so much for you to get that little, because they're not in heavy doses in the foods that we eat. So yes, we should really, really care about these deficiencies, because by the time someone has a deficiency, meaning the food they're eating is not providing sufficient of that nutrient. So we should care, because we can we can either notice that their diets are totally deficient, or we can help them and say, you see, you've been eating, say, just as an example, maybe there's a home, they're having cassava flour as their main dish. Then you tell them you could as well use the cassava flour plus the millet as well, because the millet has an additional benefit of giving you some iron, while the cassava flour doesn't. But all these are aspects of conversations that you have with patients to find out what they have access to, and then show them that, oh, among the foods you have access to, there are sources of iron. Among the foods you have access to, there are sources of calcium, as we shall see when we're talking about osteoporosis. So that way we shall be fixing the deficiencies that people may present with. And then the other really stress elements, like say selenium, it's rare that someone will have very low amounts coming in, because like I said, these nutrients are in so many foods, but we eat a lot of those foods to accumulate that little and get the daily requirement. So that means that since a food, for example, selenium is in almost every other thing, that means that we shall be able to get sufficient of it, and it's rare to have a deficiency. So are there key nutrients we should be worried about in Uganda in terms of deficiency? It's iron, zinc, calcium, and I've talked about how at least to fix the iron, and I'll talk about how to fix the calcium deficiencies. I hope I've answered that question. Kindly keep sharing your questions in the chat so that we can talk about them as we progress. And yeah, I will be talking about the calcium deficiency, so it will guide. So back to the diet-related non-communicable diseases. So the changing food environment, we are exposed to high salt, high sugar, fat. This is already known to us. So I'll just dive into what things we can do to help us change this. I put the calcium deficiency part on the other side, because it's something that's commonly presenting in adults, not in children, as we tend to have with undernutrition, but it presents in all. So I'm just again here to remind you, take home number 4. Our first take home was some severe acute malnutrition and how we can impact. We had one on stunting, we had one on anemia. Now we're having something on calcium. We have all had a chance to at least see 1 or 2 patients, or much more, with a problem with osteoporosis, easy to fracture. So what is in the bone? Calcium, phosphorus. But what is most likely to have deficiencies? Calcium. Like the question I've just read out about nutrients, and there are some that we don't need to worry about. It's very hard for someone not to have sufficient phosphorus in their diet. But for calcium, it's very common that someone doesn't have enough. For example, when women are breastfeeding, their requirement for calcium is higher than the normal adult. Theirs is 1,200, normal adult is 1,000. So we have to remind mothers to ensure that they're getting calcium sources. But if I look through our chat and use the amazing people who have been able to share with us what they are eating to establish if they are having enough calcium in the diet, we shall realize that most of us are not. So these are the calcium-rich foods. Mukena and nkeje, because of course we eat their bones, so we get sufficient calcium from them. Milk, cow milk, soya milk, okra, and green vegetables. They're good sources of iron, of calcium. But for us to get enough calcium from these foods, we don't only eat 1 serving. You can't take just 1 handful of mukene, maybe as a powder, and you're like, oh, I've got enough calcium for the day. It's very wise that we have about 3 servings. And when we talk about servings in nutrition, we mean that someone should eat 3 or 4 times a day of this food. And not forgetting the vitamin D needs, because if, like the iron story of how iron, helps the oxygen move around, the vitamin D is what helps us to ensure that we are absorbing enough calcium from our intestines to the blood, and then later on helps us to go into bone mineralization, where the calcium and the phosphorus are transferred to the bone. So there are so many of us with very busy schedules. Now we're not even talking about our patients, where we step into work before the sun is out, and we step out of that facility after the sun is out. So meaning after the sun is away, meaning that we never get any sun exposure. And so we deprive ourselves of vitamin D, yet our local diets are not so high in vitamin D. So for those of you who are listening in, also to take home lessons for your own self, kindly just, as actions for your own self, if you're not getting exposure to the sun, to allow your body to activate the vitamin D that it makes from cholesterol, because we make the vitamin D. It's a derivative of cholesterol, but it needs activation by the sun. So if you're not getting enough vitamin D, kindly remind yourself to take a few minutes in the sun to get your vitamin D. And also, if you have children who are also having this lack of exposure, let us have them also have exposure by reminding their parents that they need to put them out in the sun. So I'm going to pause again just to know if I have any questions, because it helps me to get feedback. I'm going to ask that I say one question and then proceed to this next session, just to break the cycle of only me speaking. Anyone with a question that they want to share over voice, not just chat? And then I proceed to the next. Hello? Hello? Wow. Okay. Anyone with a question? Okay, let's proceed. I don't know. Are we good? Okay. There's a lot of silence. Hello?
Yes, we are good. I think we can proceed, and then people can ask at the end, I think.
Okay, I just got concerned. Sorry about that. I just got concerned that maybe I'm off. Yeah. I hope that I'm able to share something that someone can pick a lesson from. I'm a bit going into the different sections, but at least I hope that people can have something that they have interest in, or a clinic that they are working with, and pick a lesson on it. So that's why we are jumping from different points, yeah, which I think would affect people's following, but we had only 1 hour. So let's proceed, and kindly share your questions in the chat. It helps me to know if we are picking something, and it can also help me change approach in case I don't have to follow the slides for a more conversational kind of presentation, so that we learn much more than what is prepared. So we have hyperlipidemia, which is a concern that we have commonly, and especially with adults. And it's very common that by the time we find out someone has these are tests we are doing as a lipid profile, because maybe they're presented with a condition like high blood pressure, diabetes. So we end up having these tests done. But then also, these are tests that we should have been doing maybe more routinely, because they're predictors of disease. Because we know if someone has elevated LDL cholesterol and low HDL cholesterol, which is the good one, we know that their risk of getting heart disease is higher. So that is what we are trying to fix. We are trying to ensure that people have good cholesterol, lower bad cholesterol. And to do this, it's easy, very, very easy. Very many times when we talk about nutrition, people think they have to follow a special diet. As we have seen with the first things that we have discussed, it's about knowing what nutrient is lacking and how can I fix it. Some things with these aspects of diet is that if I want to elevate, for example, the HDL cholesterol, I have to do two things. I have to increase my intake of omega-3 and 6 fatty acid-rich foods. 2, I have to eat more antioxidants. Vitamin A and C are powerful antioxidants as nutrients. And then we have pigments like lycopene in tomatoes, which is a red pigment. Chlorophyll is a green pigment in greens. And so anthocyanins is common in teas, like hibiscus tea has anthocyanins, red in color, and carotenoids, which is orange in color or yellow. These are from fruits, vegetables, red and green teas. If people were eating the rainbow, as people usually call it, eating more colors, that means they would be having opportunities to have powerful sources of antioxidants in their diet. What this would do is that it would benefit them in terms of making sure they're not having elevated levels of LDL cholesterol in their blood, because we know that when someone has a diet that is really, really high in antioxidants, antioxidants offer themselves for that oxidative reaction. So meaning you save the oxidation of other, for example, fats, free radicals. And we all know that when you prevent that from happening, you're saving yourself from a number of things. And one of them being accumulation of LDL cholesterol in your blood. So you're really doing a good job by just ensuring you have a variety of colors in your food, by just having a few omega-3 and 6 fatty acids in your diet. And I have a few pictures there to talk about some of the examples of these foods, like the pigments in turmeric, the oils in avocado, the oils in olive oil, the oils in groundnuts that's not in the picture. So these are things that people can make as a part of their day. And this also comes to talk about the concern that people usually have about food, where they're saying, is there a particular thing that does this? And very commonly, it's common that it's this food with antioxidants that are being said to do a special role in the body. Yes, they have that role, but it's not about you using them once in a week. It's not like a paracetamol when you have a headache and it kills the pain for that day. The thing with that is that for you to gain, you have to be doing this every other day. Like you eat that every day for over 3 months, and that's when you have a drop in LDL cholesterol. You eat that every day. You eat less trans fats, you eat less cholesterol, and that's when you have a drop in LDL cholesterol. And talking about cholesterol, I usually have issues with when we communicate to patients where we just make them feel like it's all bad, don't dare touch it. But then let's remember that when someone has these conditions, their daily limit for cholesterol intake in a day is less than 300 milligrams. For example, if a person eats 1 egg a day, 1 egg has 118 milligrams of cholesterol. That means that they won't have exceeded their cholesterol requirement for that day. So sometimes we scare people so much, don't do that, don't do this. And in the long run, they don't even have what they can eat. And then it also affects their compliance to these our diet recommendations. So let's not scare people off, because sometimes that scaring people off is not even necessary, as we can see here. It's just about moderation. You know that I'm not supposed to be taking in so much of it. So let me stop at 1 egg a day. Let me not exceed beyond that, because that would then give me way more than I desire. Let's think of ways to talk about, for example, trans fats. Trans fats are what is formed when, for example, when you're overheating oil, like the fried foods in commercial places, you end up forming trans fats. Trans fats are also in like Blue Band. And there are options for you to cook in such a way that avoids having trans fats. So if someone uses, for example, oil for cooking, they shouldn't overheat it. If we are walked by a chapati stand, you will smell the oil from even a distance. It's overheated, it goes past its smoke point and forms a trans fatty acid. So some of the communication about that goes beyond just saying, don't do this. It goes to, if you cook with this, don't overheat, so that we have less formation of these harmful trans fatty acids that contribute to elevation in LDL cholesterol. So let's remind people that it's easy to incorporate these actions into their diets. Then fiber-rich diets, very, very important. 30 grams of fiber a day. Do you have to take supplements for fiber? No. You just have to eat more vegetables. Do 3 servings of vegetables, a bowl of vegetables in the morning, a bowl with your lunch, a bowl with your supper. That way you have a fiber-rich diet. When you're adding the fruits as well, amazing, you have all the fiber that you need. We have noticed that when people have sufficient fiber in their diets, they end up having less accumulation of fats in their blood. So it's linked to the fact that fiber may be reducing absorption of some of these fats. And it doesn't only do that for the fats, it also does it for some of the toxins like heavy metals. I think it's vital because it's a common thing that people will say, and detoxing, which I think for me is not necessarily a thing, because you don't have to do that once in a while. These are things you help your body do. The body does it. You don't detox for your body. The body does the detoxing. You help your body by providing it with the nutrients like the antioxidants to help you with this. And an amazing example with the fiber is how there's a study that was done on, for example, heavy metals. Let's say we have lead contamination in our water. And it was noticed that if, for example, group A has accumulation of has a lot of heavy metals in their diet and group B doesn't. Sorry, group A and B both have heavy metals in their diet, and group A eats a lot of fiber and group B doesn't. We notice that group A that's eating lots of fiber with those meals ends up having some of those heavy metals, which we can say are, bad for our body. Some of those heavy metals end up in the stool because the fiber chelates with some of them, and they are not absorbed into the body. While the group that doesn't have fiber ends up absorbing much more of those heavy metals. So I'm here to remind you that sometimes the things that our patients look out for in alternative medicine, where they're telling them you're going to clean your system, etc. Some of these things diet does by just you making sure you're eating sufficient amounts of fiber every day. So you don't have to wait for your patients to start trying very drastic measures of, I have to detox. No, have them eat these amazing things, more fiber, more antioxidants every other day, and they will be supporting their bodies to do what it's supposed to do without waiting for special times to buy special things for that process. And of course, moderate the simple sugars like added sugar, have less calories coming into your diet, because now if you're having a diet that is already causing you to have elevated fat in your blood, bad fats, and then you have obesity combined with that, you're definitely going to be at a higher risk of getting some of these conditions like diabetes and heart disease. So let us always encourage patients, not only when they are sick, but if you find, for example, a teenager who is obese, talk to them about some of these things. Okay, I spent a lot of time on that, but I hope that it was beneficial. Let me proceed to the next. Like I said, I am giving different conditions and the goals of nutrition care and the possible outcomes that then make health better for our patients. So I understand you already had sessions on diabetes, so I don't plan to take so long on this. I hope that is true, but I'm just going to highlight a few things here. And I'm also looking at the questions. Okay, let me just highlight a few things on diabetes care. This is one of the things I really like to do, especially with people who are pre-diabetic, when someone has just been diagnosed as diabetic. Amazing experience with these patients. They walk in anxious, they walk in scared. Recently, someone said that, yes, they told me I have diabetes. Can you believe they told me I can't eat anything? I don't blame the person who has told them not to eat certain foods, because sometimes we don't have enough time to explain to them how to count the carbohydrate, how to avoid a high glycemic load. We don't have all that time. So sometimes we end up saying, avoid this, avoid that, avoid this. But I'm here to say that if you have more time with your patient, don't just say anxious. They worry and they can do the don'ts for like a week when they're highly motivated. And after that, they're back to eating the way they want to eat. This is what I do instead of don't. I sit down with the person and ask them what they have access to, especially in terms of carbohydrates, because we go down to form glucose as well. So why should I overload glucose that I'm not able to control? So the goal of care in a diabetic diet is really to just lower the glycemic load, reduce the chances of spikes in blood sugar levels by offering foods that don't give spikes in, like, for example, we are leaving out honey and overly ripe fruits. But then it's important, sit down with this person, ask them, what do you have access to? You're going to find a diabetic who has only been eating posho all their life, and that's what they can afford. And then you're telling them when they're diagnosed, do not eat posho. It's not practical. I mean, we have countries with staples of rice. We can't tell them don't eat rice. It's not practical. So we need to sit down with these people and tell them, look here, these are the food options that you have. What amount of sugars is in this food? Understand how much is there. And then teach them how to count that food and eat only the quantity that doesn't overspike their sugar levels. I have people who only have access to cassava. Tell them what size of cassava they can eat. I'm not here saying that all of them can eat it, but in case we have situations where they don't have access to the lower glycemic load carbohydrates like matoke, which is the best option, or Irish potatoes, and talk to them about what they have access to. That way they can eat healthy for life. They can eat healthy together with their family without having special budgets to just buy diabetic care foods. It's very, very important to personalize this information. And fiber is amazing. I've just spent a little time on the other slide talking about fiber and its effects on reducing absorption of contaminants like heavy metals and fat. And then fiber comes in and then does this other amazing job of, if you have a high fiber meal and you're both diabetic and that person doesn't have a high fiber meal, the person with a high fiber meal has less spikes in blood sugars because there is a slow release of sugar from the gut to the blood. So you're benefiting your health just by ensuring there's a fiber serving on your meal. I find this very amazing because it then makes health messaging easy because we are seeing fiber being repeated everywhere. So that's why we say, make sure the patients are eating sufficient vegetables because it's doing a number of things. It's bringing us the nutrients, it's bringing us the iron, it's bringing us some of the calcium. It's helping us with every diabetic. Should have a drop in body weight. For an obese person, there's an improvement in managing their blood glucose levels. Let these patients keep taking this medication, but don't let them keep increasing their dose all the time. Every time they come, the sugars are way higher. You add a dose, yet you haven't had a conversation with them about what are you eating? Because to what extent are you going to keep increasing the dosages? Because I even know patients whom I've talked to and they tell me, nah, Mia, it's okay, I eat what I want. I go, when I want to take a lot of alcohol, I go, I even take more medicine than what was prescribed so that I can enjoy my alcohol. Or I've had people who say, I'm going to sit on my basket of bananas. After all, I can just take double the dose and my sugars will be fine. We have patients having such statements, which is really sad. I think we can teach them gradually to appreciate the impact of food and teach them to learn to eat in moderation so that we have better control from the diet, and then we complement it with the medical care, which gives us the best control and avoids the other conditions that are associated with diabetes. And, less hospital stays is a healthy person. A healthy person is a happy person. Sometimes when we talk about this, people say that, but it's not possible for the person to not keep visiting the hospital. We are not telling them as dietitians not to visit the hospital. We are telling them, visit the hospital, take your medicine, but eat healthy so that you're not increasing your problems and increasing the chances of getting other problems. And you see what this does to you as a health worker is that it makes the patient know that indeed you're helping them. Because, but I've heard that juices and fruits are nice. So I'm going to buy a blender and I'll keep making a lot of juice because juice is healthy. juice should help me lower my sugar levels. I'm like, you're going to be worsening this because you're going to be getting a blend of fruits with a high glucose load and creating a problem. But no one had told them about this. And when they learn about that, you save a life. And that's the true healthcare. I've also had situations where people walk out of a hospital, and I think this was during my internship some years back, over 5 years ago, where I would sit in a taxi going home and hear someone say, oh, they've told me I'm a new diagnosed diabetic. Now they've told me that I can't take soda. Then the friend said, no, you can actually take soda. You see, there is this bitter lemon, the bitter lemon soda. That one is bitter. Bitter things cut sugar levels. That one you can take. Such small misinformation we can fix by just having conversations about food with our patients so that we don't let them walk out with unanswered questions out to the world to be misinformed. Thank you for listening to that. Let me proceed to the next. I saw some questions on the chat. How much time do I have left? Honey has a high glycemic index, yes. We do. I'm seeing questions on the chat about the last slide so that I don't have to go to it. Yes, it does have a high glycemic index, and it actually has a high glucose load as well as compared to sugar. Because, okay, let me talk in terms of calories even. A tablespoon of honey actually has more calories than a tablespoon of sugar. And so let's really ensure that we are not you really want to moderate the honey as well. Actually, if possible, limit and don't use foods that have glycemic index is how the food releases sugar into the blood. Yes, it releases at a faster pace. Thank you very much, Benon. I think these are just additions. Thank you. That's very true. Did you say that honey has high levels of sugar? So yes. If someone is diabetic, let them not use honey. Of course, people struggle with deviating from. People struggle to find foods that they can enjoy when they are diabetic. You've been taking sugar, and all of a sudden they're saying don't use it. So you want something sweet. In case the person struggles with taking things that have no sugar at all, let them use like things that don't have a glucose yield but are sweet, like stevia. Stevia is sweet. It's a plant leaf that is sweet, but it doesn't have a contribution to your glucose. Or in case that really fails, we can use artificial sweeteners. Am I saying every diabetic should use stevia and artificial sweeteners? No. I'm saying if a diabetic struggles with the behavior of learning to enjoy food that has no sweetness, I'm better off them using artificial sweeteners, preferably natural sweetener like stevia, so that they can enjoy the food instead of me telling them nothing is possible, and they end up taking a soda, they end up taking a fruit juice, or they end up taking honey and sugar. I would rather they take something that doesn't have an effect on their glucose levels. So first, try to have them not take anything sweet, but if that fails, offer an alternative. Should we fear aflatoxins in Ugandan cereals? Yes, we should fear them, but of course, you can always buy from as fresh as possible. I'm not going to go into that because I've already used an hour. But let me just talk briefly about this. Dietary approach to stop hypertension. This is how it is called. It's a name. I was discussing with someone and telling me that sounds big. To stop? Can you stop it? No, I'm not here to stop it or to say someone is no longer hypertensive, but this is the term used for this diet. And there are so many things that we can do to help the person actually reduce the number on their blood pressure reading. And some of them, like exercise, like those for dancing and exercise, like to do gym, simple things, being active every day can have an impact on your blood pressure. And then the other thing, I'm going from up, going down. The other one is alcohol intake. Amazing impact, amazing impact. You can see I cropped out a message from a client of mine who has dropped their alcohol intake, and it's miraculously working for them, because we know for every increase in alcohol intake, we have an increase in blood pressure. So for every drop in alcohol consumption, your patient will actually get a drop in blood pressure. So sometimes you're managing so much, but the patient still presents with problems. And every time the patient is not managing well, you're the one who gets more questions. And if they have your number, they will even call more, but doctor, you gave me this, but still my pressure is high. Meanwhile, they're sipping alcohol while they take that medicine. So sometimes we have to have conversations with them. I respect the counselors and how they can really come to the bottom of why someone is attached to all that alcohol. Sometimes it doesn't mean the person is alcoholic. Maybe they're drinking for social reasons, to help them just detach from it. Be surprised, people are taking over 20, 30 bottles of beer a month. It's a lot coming into our bodies. It has an impact on blood pressure. And potassium is from bananas, avocado, vegetables mainly. We have these sources of potassium. But of course, we have to take caution that if case we have a person who is hypertensive, but also having a kidney disease, there might be a need to restrict on potassium. So there you have to choose the kidney disease care, where if they have issues with potassium, you remove potassium, you use, you make sure they're not having a high potassium intake, because the impact on the kidneys is worse if they have a lot of potassium coming in. So this is just a reminder that nutrition can be really, really individualized, because I am saying increase potassium, but you will have patients who have both kidney disease that and maybe they're on dialysis and also have hypertension. So you have to put the two into play. Then sodium. We ensure that we are having less than 1,500 milligrams. Of course, you can't tell the patient to make sure you're having this amount, but what you can tell them is with every meal they have, they should have no more than a pinch of salt. Because if you have just a pinch of salt, total in a day will be less than a teaspoon, which will be within the sodium requirements. Patients struggle with reducing salt in their diets. And then there's some people who tell them stop salt. Very, very not practical. Tell the patient that salt is something that you add to your food to enhance taste, but you can reduce your salt intake by enhancing the taste using natural herbs and spices. Use garlic, use turmeric, use white pepper. Enhance the taste with these natural herbs and spices. That way you don't have to put excess salt in your food, because you have an amazing taste coming up already. Okay. Next. Again, like I said, I'm having a journey. We are like moving from one station to another. We have come from underweight to anemia to calcium to hypertension and diabetes, and we are going into another station now about constipation, because I thought, we can have a few insights here and there about things that can help our patients. So at least each of us has picked one or two things about a patient we probably saw today. Now, constipation. And I think I'll probably just use like 3-4 minutes, and then I'll conclude so that I don't go over the time, to allow you to ask questions. I'm going to stop on the constipation slide and go to the conclusion slide to allow room for questions. Constipation is something I like to talk about. Why? Because even among us ourselves, because we sit a lot, because we tend to not eat high fiber meals, we have a lot of those cases. And then, of course, if any of us has worked with bedridden patients, these cases are way more. And this is because they will definitely be having a diet that is low in fiber, because rarely does someone come to the hospital and give a high fiber meal to a patient who has been in hospital for a while. But I'm here to remind you that it's possible for them as well to eat high fiber meals. They can blend up these fibers and take the foods and see, like when you make a juice and blend it but you don't sieve, the person will have a high fiber intake. Then we also have the soluble fiber version in avocado, bananas. It's not that fibrous, like roughages, but it's there. So it's soft. It's not hard to incorporate in foods like baby foods and hospital and ill patient foods, but it provides you the fiber. What does this fiber do, and why 30 grams daily? 30 grams daily, by the way, is the actual fiber. And for us to hit that number, we need to eat about 3-5 servings of fruit and vegetables. Again, comes back to why we keep telling people to eat a lot of vegetables. And of course, water as well. So what fiber does is, like, fiber acts like, I like to say it acts like a blanket. When a blanket is in a benson, and you pour water over it, a blanket or a mattress, it holds up all that water. So that's what fiber really does. Fiber has the ability to just take in water and hold it up, so that you have stool that is really, really, really soft. And that way you prevent things like hemorrhoids, which is caused by straining during bowel movements, just by eating fiber. Simple solutions to big problems that some of our patients think are normal. Some of them don't even talk about constipation with us because they think that's a normal part of life. I don't think it's a problem that I strain while having my bowel movements. I won't even tell the doctor about it. So let's have these conversations about fiber. You'll be surprised how many people you'll be helping. Okay, skipping the aspect of weight loss, because that's a really big conversation on its own, because I'm not sure how much time I have. Question about what has Regina been talking about? What is this thing with diet? The key take-home message is a healthy plate. Because you realize that almost all the things I'm talking about are not every single day. What do you do to incorporate them into your diet? You just have a healthy plate. Quarter of it, you have energy. You can see on my plate there, it's a client's plate actually I'm sharing. He had gonja, so that's his source of energy. This can even be a diabetic meal, a weight loss meal, because it has just enough energy. It has gonja as a source of energy. It has lots of vegetables which help with satiety, so you're very full. Then the brown thing over there is fish. So you can get a healthy plate, fill it up so that you get sufficient. So in case you don't have time to talk to a patient about healthy eating, key take-home message, tell people to have a healthy plate. Healthy plate, healthy plate, healthy plate. It will be more colorful. It will have antioxidants. It will have just enough energy, not excess. Some of us are even looking at this plate and thinking it's not enough food because we are used to overloading our bodies with energy, which ends up anyway resulting into excess weight. So we have to understand what healthy eating means. And that means a healthy plate. As I conclude, yes, I've talked about all these things. It's evidence-based. When you lower alcohol intake, you will improve blood pressure. When you have low glycemic index, you will have better blood glucose control. When you eat fiber, you prevent constipation. When you have antioxidants, you'll have better lipid profile. Theory. Some of us even already know these things. But the actual practice requires a behavior change. The actual practice requires a behavior change. It requires the person to be ready to take action, to change what they eat, to shop better, to buy better, to cook better. So we have stages of change, which I believe most of us know about. Someone contemplates, later on they prepare, and they take action. And then they go into a maintenance phase. But for me as a dietitian, the biggest thing that I really see happening is the relapses. Someone starts healthy eating, they do it for 3 days, 4th day, they're already relapsing back to their unhealthy habits. So that's why I find it very important that we strengthen the core of nutrition counseling. And I think I kept mentioning it, have conversations in depth about food. Don't leave it at the surface. Not just assume because someone is scared of getting diabetes, they will just eat healthy. No, have conversations about what is affordable, what is practical, why are you eating like this? And then that way you can change them. And I think that's what the dietitian does, is you just go in depth with the patient. And for us also at Impact Nutrition, we do reminders, we motivate here and there, and then we make our patients accountable to us. We ask them to share pictures of their plates. We ask them to share challenges so that we are sure that they're addressing any of the food concerns that they have. And then we have a lot of follow-up sessions as well. So in case you struggle with helping people change this behavior, or even your own self, don't be unhealthy when you're providing health to others. Please talk to us and we can always help. Just to summarize that again, I just put this up to just show you the different ways we can actually end up providing nutrition all through. When the patient is at triage, let's look out for their weight. Let's look out for their mark. Let's look out for the clinical signs. The person looks pale. Let's already think maybe they need to think about their iron. Let's be alert for the cues that we have about nutrition as they're in the waiting area. For those of us in public hospitals with large waiting areas, we can do a group nutrition education session. We can have something rolling on our screen. During the laboratory, do we take concern when someone has low calcium on their numbers, low HB, lipid profiles? Do we take concern to make this a trigger for a need for nutrition guidance? When you're in the consultation room, when you're doing a ward round, are you alert on the medical conditions that will require nutrition counseling and diet planning? And as they check out, do they get information? Is there anything you're providing in terms of diet guides so that people get the right nutrition guidance from us? Because we know that most of the health information shared online is the most shared is actually the less authentic. We have all read those articles online and we roll eyes and think, people really think this is true health information. Now it's worse for us as dietitians. There's so much on the internet about food and most of it is not really guiding. And even when it's guiding, we all know that we have information, but we never take action, which I was talking about with behavior change. So let us help people eat healthy, because at the end of the day, they then appreciate us as health workers in general, because they know that when I go to that health worker, the problem is fixed. The problem is fixed. It's not me being diagnosed with diabetes, but I'm never told that Crest soda doesn't burn sugar. So I keep taking it. And then I just say that facility, since I have been there, I've never had healthier blood sugar levels. Then they'll come to another facility where there's holistic health care. They provide them with the medical consultation. They tell them about the food and they have better sugar levels. And I think at the end of the day, they will have a good outcome. And as I conclude, I think I will have used exactly 1 hour then, because I think I started about 2015. These are some of the benefits of prompt nutrition care. And I'm just summarizing this here on this slide to show you that what I'm talking about with the theoretical evidence-based information I was giving is things that I have shown people how to do through facilities, through individual consultations. And we have an example right there of a mother with a good breast milk supply. This is a mother who is going to work and she's able to pump over nearly 300 mils of milk for the baby. So meaning this working mother leaves her baby with good milk supply. Strong bonds, immunity. We have all had these cases of COVID. And even in your own home, some of you, the child comes from school with a flu, the whole family gets flu, and then you start to buy the vitamin C supplements after the exposure. But if you are eating vitamin C rich foods every day, you would have a strong immunity to benefits as fat loss. I do amazing things with body fat loss, and it all goes back to behavior change. You can see that message about someone saying, I didn't know I would lose weight without ever taking supplements. So some people think that they have to take a certain pill, but it's behavior, the healthy plate. Before you know it, the weight is down, which is literally fat loss, to a healthy BMI. Because when you have a healthy BMI, we have a less risk of disease. And then to things like blood glucose control, we can see we have an amazing message over there about 2 years back from someone. I found it very exciting that, they get their first diagnosis at 22.6 back to 5.4. So For me, that's indeed a benefit to prompt nutrition care. I am Regina Nantege again. I started a bit with, hiccups here and there. Sorry about that, but thank you for listening to me for over an hour. I look forward to your amazing questions. I do health talks, I do clinical services for health facilities, personal dietitian work,